Thank you for that introduction. So, this talk is entitled Treatment and Response Over Time in Women with Urgency Incontinence, a Novel Approach. All right, so just briefly, urinary incontinence is the leakage of urine associated with a sudden desire to void without other cause. Approximately 30% of women over the age of 30 experience urinary incontinence, and the prevalence continues to increase with increasing age. The pathophysiology is quite complex, but we do know it's associated with mood disorders, diabetes mellitus, age, frailty, cardiovascular disease, and other disorders. In terms of treatment, we typically start with behavioral modifications and physical therapy, and then move on to medications. And our third line therapy includes onabotulinum toxin A or Botox, sacral neuromodulation, and percutaneous tibial nerve stimulation. I'll be focusing on Botox and sacral neuromodulation. And very briefly, Botox is a cystoscopic injection which causes paralysis of the detrusor muscle by acting at the nerve terminal, whereas sacral neuromodulation involves implanting an electrode into either the S3 or S4 foramen and likely modulates the afferent signals from the bladder. Now, both of these procedures are considered nearly equivalent in terms of outcomes, so we're currently offering them both to all patients who have failed prior therapy. So what do we know so far about these two therapies? Well, there was a well-designed, multi-center randomized control trial that was conducted by the NICHD's Pelvic Floor Disorders Network, or PFDN. And this study looked at women with refractory urinary incontinence, meaning those who had failed prior therapy. And these women were randomized to either Botox or sacral neuromodulation and followed for about 24 months. Now, the great thing about this trial is that they recorded many outcomes at frequent time intervals over the 24 months, including bladder diary data, post-void residuals, urinalyses, and many patient-reported outcomes. Specifically for my interest, they included both mobility and mood. Now, the primary outcome for the Rosetta trial was change from baseline in daily urinary incontinence episodes over 6 months. And they analyzed these outcomes similar to how most studies do, and that's using a linear mixed model or repeated measure. So what a linear mixed model is in essence, it averages data at each time point. So for this study, time points between baseline and 6 months, and it gives you a single value. So the results for the Rosetta trial showed that Botox, there was on average a 3.9 reduction in daily urinary incontinence episodes, whereas for sacral neuromodulation, there was a reduction of 3.3 in daily urinary incontinence episodes. But there is so much more to treatment outcomes than just this single number. And you can see that here. So this is one patient from the Rosetta trial who received sacral neuromodulation. So the x-axis shows time with baseline on the left and 24 months on the right. And the y-axis is number of daily urinary incontinence episodes. So this woman started with around 6 urinary incontinence episodes per day and improved after her interstim, but then kind of bounced back to where her baseline was and remained nearly at her baseline for the 24 months. This patient, on the other hand, is another subject from the Rosetta trial who received sacral neuromodulation, but she had a bit of a different treatment outcome. So again, the x-axis here is baseline on the left and 24 months on the right. And then the y-axis is the number of daily urinary incontinence episodes. So this patient, again, started around the same. So she had 5 urinary incontinence episodes a day. But after her interstim, she had a dramatic improvement and kind of kept that improvement over the 24 months. So when you place these two side by side, you can really see the difference in their treatment response. And giving both of these women just one number really is not the most accurate prediction of their expected outcome. So the first aim of this grant is to use the data from the Rosetta trial to evaluate the use of applying a recurrent event analysis to understand both objective and subjective treatment failure over 24 months. So the recurrent event analysis is, in essence, used to describe these fluctuations in urinary incontinence episodes per time. So again, it doesn't give you just one value, it gives you this description of these fluctuations. Our second aim is to look at the association of modifiable factors with treatment failure over 24 months. And specifically, we'll be looking at change in mobility, change in mood, change in cognition, the occurrence of urinary tract infection, and voiding dysfunction. Our third aim is to evaluate longitudinal patterns of treatment failure over 24 months. So, if we come back to our two patients who received sacral neuromodulation, this objective aims to classify these patients into different categories of treatment response. So, one potential outcome for this aim is classifying the patient on the left as a persistent failure and the patient on the right as a persistent success. And my final aim is to evaluate subtypes of patients receiving treatment for urinary incontinence and evaluate the association with different treatment failure subtypes from the previous aim. So that might look like a woman who has recurrent urinary tract infections, maybe impaired mobility, maybe anxiety or depression, and all of those characteristics may be associated with this persistent failure subtype. Whereas maybe an obese woman, someone with pretty consistent mobility and diabetes mellitus, perhaps those characteristics are associated with persistent success treatment failure subtype. So hopefully, in terms of future directions with this grant, I'm hoping that it will change the way that we analyze trials involving urinary incontinence, allowing us to have more information and data. It may also pave the way for a large prospective cohort study exploring the impact of mobility, frailty, and mood disorders over time on the natural history of and treatment for urinary incontinence. It might also lead to a study evaluating the use of ancillary treatments such as physical rehabilitation and cognitive behavioral therapy on urinary incontinence. And finally, it may lead to the development of prediction models for specific longitudinal treatment subtypes. All right, thank you for your attention, and I look forward to your questions.